On today's topic, because I am so excited about our guest tonight, I wanted to tell you a little bit about what the Rodham Institute has been up to, because we've been very, very busy. As you know, what we do at the Rodham Institute, we are action oriented. We're not just about identifying disparities. We feel very strongly that those have been identified quite a bit, and that the COVID pandemic simply took off the veil for some people who were not aware of just how bad the disparities were. COVID is just the most recent example. But I'm proud to tell you that over the past year, we have had over 40 webinars, such as the one that we're having tonight. We've distributed 560,000 masks and hand sanitizers. And this was through a generous donation by Mr. Kim, who is a businessman. And he went up to Dr. Raymond Tu, the former CMO of United, and said, look, I've got all this excess inventory. Where should I sell it? And Dr. Tu, who's a friend of the Rodham Institute, says, don't sell it. I know an organization where you can donate it to. So we thank you for that very generous donation. And I will tell you that these are masks that are actually have 4 layers, so that they are actually appropriate for the new strains that are even more contagious. The other thing that I'm very excited to share with you is that on April 3rd, Ms. Cora Masters-Berry, the founder of the Southeast Tennyson Learning Center and the former First Lady of Washington, D.C., invited the Rodham Institute to have a mass vaccination event. So what we have done is we brought all our partners and our friends, and the residents of Ward 8, just the 2 zip codes, are being signed up by, registered by community-based organizations that work there. And not only are we going to have the vaccines from all of the different hospitals that are going to be working to vaccinate together, the city is giving 1,000 Johnson and Johnson vaccines. But we're going to have Howard and GW and Children's and Georgetown and MedStar all working together. But we're also going to have our colleagues from the food space, the mental health space, as well as the Medicaid CMOs to re-engage people into care, and also to get them signed up for mental health services and food services. I think this is kind of the perfect segue for me to talk about the topic at hand. March is Colorectal Cancer Awareness Month. And before I introduce the guests, I mean, everybody's so focused on COVID. We have forgotten that there are actually many illnesses that continue. A very sobering statistic is that there's actually been a 30% reduction in new cancer diagnosis. That's not a good thing. That means that there are at least that many people who have not been diagnosed. So that's bad. Or when they do get diagnosed, it'll be at a much further stage in their diagnosis. I just received something from one of the insurance companies that said there has been a decrease in 63% of people attending their chemo appointments. So I think that it is super important to get the vaccine to get protected from COVID, but it is also important that we have a parallel track of thinking about all of the other illnesses and screenings that we can do. So without further ado, I'm going to do this in alphabetical order. I'm going to introduce Dr. Lynt Johnson. He is the head of our liver transplant team. He's a surgeon, and we are delighted that he's joined us this evening. And then Dr. Obias, who is a professor of colorectal surgery and is the head of the division of colorectal surgery. So welcome, gentlemen. Thank you for joining us tonight. Really appreciate it.
Thank you very much.
Thank you for having us.
Sure. So I'm just going to sort of throw out a question. I mean, and you're both surgeons. You both take care of people who have colon cancer. What are you seeing in terms of your practice? Are you, it's been a year now since COVID hit. Are you seeing people sort of at further stages than maybe a year ago, or is it too early to tell? Dr. Obias?
Yes. So I have definitely seen a drop in colon cancer, and I've seen more patients coming into the hospital at a more extreme level of blockage and perforation. And of course, if the cancer gets to that point where it's grown so bad, where it's blocked you or caused a perforation, then it's obviously a very advanced cancer and your outcomes are or worse. Many of these patients would have gotten a colonoscopy or screening earlier in life, and it's really sad, quite honestly. And it's not even just the cancers across the board, just benign things like gallbladders and appendicitis, things that we would normally have intervened so early on, now come in perforations, and really a difficult situation. But colon cancer, absolutely, our volumes and numbers have dropped, and we're seeing an uptick in admissions to the hospital directly, and fewer coming in and screening. There are still GI groups that haven't gone up to their normal levels in doing screening colonoscopies, and that's very scary.
So we're not all doctors or nurses or clinicians that are listening. So what's a perforation? You said perforation. What is that?
Yes, so that's where they end up having a hole in the colon where the cancer gets so large it actually eats through the entire wall of the colon, and then there's a hole in it. So, that at that point you can have a spillage of stool and the patient becomes very sick. So, we take care of those patients all the time. But I do feel like we've seen on a personal level an uptick like that.
Okay. And Dr. Johnson, just take us through some basics. Colon cancer, really, what is it and who is impacted?
Yeah, so first of all, your colon performs very important functions for you. Obviously, we all know that we have bowel movements, and that comes from our colon. Most of the nutrients that we eat get absorbed through what's called the small intestine. That is the part of the intestine before the end part of the intestine, which is the large intestine, which is the colon. And the colon is very much involved in actually absorption of the water or liquids from the food particles and the secretions in our intestines, and ultimately eliminating that waste. And usually colon cancer occurs because of mutations that occur in the cells of the lining of the colon, which causes those cells to pretty much never turn off. And so all of our cells divide, and then they stop and they live a normal cell life, and then they go on to die. Well, in colon cancer, that sequence of cell division and cell life and cell death becomes disrupted. So cells continuously are on, and that's what forms these tumors and mutations in many of these cycles.
So that's true with really any cancer. Cancer is when cells that usually grow in an order, like let's say a red blood cell lives about 120 days, and then it naturally dies. But when these cells, no matter where they originate from, the colon, the skin, the brain, the breast, whatever we're talking about, start to just basically ignore what's happening from the control and command center and say, we're going to do our own thing. And then they start to take over in places where they shouldn't be. Yeah. So Dr. Obias, who is at risk for developing colon cancer? Who gets into trouble with that?
Surely. Actually, so the older one gets, the higher your risk. So it's not just, a myth is that, maybe only a certain population is at risk or needs to worry about colon cancer. We should all worry about colon cancer because the older we get, the higher risk we have of colon cancer. And that's why we are recommending getting a colon cancer. It used to be at 50, and now we're even pushing it to 45 because we are seeing colon cancer in a much younger age. Other risks associated with colon cancer, or who you think about is, if your family history, if your father or mother had colon cancer or colon polyps, you do need to get colonoscopies at a younger age. Even your grandparents, there are some syndromes associated that have a higher risk, and certain medical conditions like ulcerative colitis and Crohn's disease increase your chance of having colon cancer.
So, we've been hearing a lot in the news since the death of Chad Boseman, the Black Panther movie star who unfortunately died very, very young of colon cancer. So Dr. Johnson, talk to us about colon cancer in the African-American community. Does it occur at a younger age or stage? Should African-Americans get screened younger?
So a couple of facts that everyone should know. First of all, the incidence, that is the number of cases per a unit population, is about 20% higher in African Americans than it is in our Caucasian brothers and sisters. And also more importantly, the mortality or the death rate associated with colon cancer is much higher in African Americans than they are in other ethnic groups. And also there's an association with colon cancer coming on earlier in age. And Dr. Bias, will obviously speak to this, but there, because I've come from a different hospital, I've seen colon cancer at a hospital where the patients that utilize the hospital are different from a demographic standpoint. The number of young individuals with colon cancer seen here is astronomical,
Yeah.
and many times they come in with very advanced disease. As you mentioned, Chad Boswick was in his early 40s when he contracted the disease process. And when I was in training, this only occurred in patients who were 70 and 80 years of age, at least that we saw in the hospital. So there clearly, I think, are differences in terms of the risk of colon cancer, but also there are differences in regards to the paying screening earlier in age.
So, there's a lot of discussion about the disparities. Why is it that even for the same stage of disease, let's say in breast cancer, even colon cancer, that African Americans have higher death rates? And this is what we call the structural and social determinants of health, that 20% of outcomes are actually due to access to a health system, but 80% has to do with the food you eat, the water that you drink, the air that you breathe, your level of education, the economic health of the neighborhood that you live in. But also we know that oftentimes, and this has been, I think, I'm familiar with the breast cancer literature more than colon cancer, but there's often a delay in somebody coming in. Let's say a woman comes in with a breast lump and then getting a mammogram, an African American woman, that space or that time interval can be a lot longer than, let's say, her white counterpart. And then even after she gets diagnosed, the amount of time that passes between diagnosis and treatment is sometimes double the time. So there are lots and lots of factors, but let's talk about, to the audience today, about what things people can do now. We know, for example, that there are certain diets and certain substances, diets that they should follow and substances that they should avoid. Dr. Obias, can you enlighten us?
Certainly. Well, as a colorectal surgeon, we love our fiber. And I have to admit, a high fiber diet, low fat diet there's been some large population studies that demonstrate that it does reduce your risk of cancer. So makes you more regular, less constipated, less, loose stool, and that has been shown to maybe reduce your risk. The other one is smoking. There's definitely a correlation in smoking and colon cancer. It's associated also with lung cancer and a variety of other scenarios. So smoking, reducing that. Also, some studies showing, high ingestion of alcohol as well. So if you kind of live that clean life, it slightly improves your odds of reducing your risk for colon cancer.
So when you say fiber, what do you mean? I mean,
Yeah.
do we have to see those things that are advertised on TV, or are those better than, certain fruits and vegetables? But what do you suggest?
So, the average American gets about 12 grams of fiber. And, the FDA, the Federal Drug and Association, really focuses on fiber about 25 to 30 grams. And honestly, Metamucil is like 4 grams. So, but we're so low on fiber that going from 12 to 16 will really help our bowel movement and regularity. Good examples of fiber would be things like oatmeal, whole grains, sort of more insoluble fiber than soluble. So things like that. Another nice thing is supplements. They're natural. Psyllium, Metamucil is another common over-the-counter fiber that we take. You can get leafy greens, but interestingly enough, certain fruits have a higher fiber than just a salad. So, an apple a day, maybe 2 apples a day will keep the colorectal surgeon away.
Well, I was rushing to get home from clinic, and I now carry apples in my purse. So I was able to eat one of them. And, I think sometimes, just from a practical standpoint, we are told all these things about eating more fruits and vegetables. But the reality is that,
Right.
having something convenient that's cut up, that I always just throw it in my purse so that I can
Yeah.
eat it, in between patients or on the way home, and it actually helps to curb my appetite once I do get home. These are little tricks
Mhm.
that can help, and can also help in managing or losing weight. So you gave us some good tips. So no smoking,
That's right.
alcohol. I would like to just talk about alcohol for a second, because sometimes in the media, people get all kinds of mixed messages. You hear on one hand, well, alcohol is good for the heart, but then you hear cancer. Well, and they say, well, the French don't have heart attacks. Yeah, but the French also die at a higher rate of cancer than we do. So when you look at these recommendations, you have to look at everything, not just one disease. So for women, for example, studies show that when women have more than 7 alcoholic drinks a week, and I want to say one shot of liquor, hard liquor, is the same as a glass of wine, is the same as a can of beer, because you make up in volume, so they're equivalent. Women metabolize alcohol more slowly than men. So all those myths that you saw growing up, that it's easier to get a woman, drunker quicker, that's actually true. Men can have up to 14 drinks. Okay. When the 7 or 14 is surpassed in a week, guess what? Cancer rates really start to go up. That's a story that I don't think gets told often enough in terms of the media. So we talked about diet. We can't change our parents, our genes. You mentioned certain diseases, and I just want to come back to them. They include polyps, which a lot of people can have, and you can't know that you have them until you have a colonoscopy, and the inflammatory bowel disease, which is Crohn's and ulcerative colitis, but not irritable bowel syndrome. Is that right, Dr. Obias? What's
Yeah.
the difference there?
Yeah, irritable bowel is associated with, constipation and diarrhea, just irregularities in bowel habits, but it's not necessarily intrinsic to the colon disease itself. Certain medications may help that, but Crohn's disease is associated with chronic infection or inflammation of the colon. Ulcerative colitis, again, chronic infection and inflammation. But irritable bowel isn't a disease like in that regard. Now, that being said, patients could have some GI issues of constipation or irregularity, and that is a symptom of maybe, cancer. So if you have a big enough cancer, you could have a blockage. Certain very large precancerous polyps can cause you to have diarrhea. So indications for screening aren't just family history or history of Crohn's disease. It's also if you have a change in your stool pattern. So, all of us, you've been chugging along great for years, and all of a sudden you go once a week now and you don't know why, and you're more distended, or your belly's bigger, or, you're doing okay, and all of a sudden you're starting to see some blood in your stool, or your stool looks different to you. These are, even though you're younger, these are good enough reasons to see a doctor.
Yeah. Well, so I want to come back to that. And Dr. Johnson, please help us out, because sometimes people get caught up with screening versus if they're having symptoms. So because I've seen this unfortunately happen with women with breast cancer. They say, oh, I just had a mammogram a year ago, and they have, a new breast lump. And then they'll say, well, I just had my mammogram, then it couldn't be cancer. So can you help explain the difference between screening for people who don't have symptoms and what the protocol is for people who do have symptoms?
Yeah, so, the currently, as Dr. Obias mentioned, the recommendations are that individuals get screened for colon cancer between the ages of 45 and 50. And normally individuals who have a clean colonoscopy at that original date will not have to get another colonoscopy for 10 years. That time interval is shortened if there is an abnormality found, for instance, a polyp on the colonoscopy during that screening process, or if the individual is deemed high risk because of family history and other factors that come into play. One of the things that just for individuals to understand what's coming in the future is that there are a number of companies that are now looking at what we call liquid biopsies to screen for colon cancer. And so these are blood tests that look at certain what we call genomic signatures that are sloughed, if you will, into the bloodstream in a very minute quantity that can be expanded and identified in patients who have colon cancer. And this technology is not something that, you know, is going to be 10, 20 years from now. The first large trials will ultimately be reported at the end of this year. And I suspect that within the next 3 to 4 years, this will become a part of our screening process for colon cancer and perhaps for some other cancers as well, which obviously will be less intrusive than having to do, you know, the bowel prep, take a day off from work and go in through the sedation and get colonoscopy. And so hopefully by making these screening processes easier, we'll get a higher compliance rate amongst individuals, because clearly if we're able to detect cancers, particularly colon cancer early, individuals can be cured of their disease. And that's really what we want.
Right. I mean, and for people who have polyps, which can be precancerous, those can be removed before they even have a chance to turn into cancer. So, Dr. Obias, if somebody has been told that they have a family history of polyps, or they have had polyps themselves, can they get this Cologuard test?
So the Cologuard test is a test that actually, if you already have a history of colon cancer, it's kind of contraindicated because it'll always come back positive.
What does contraindicated mean?
Yeah, they don't recommend it because it'll always come back positive. But if you've not been screened and you're at high risk, it certainly is an option. And that's sort of where you basically, they basically take a sample of your stool and they analyze it. Now, that being said, we have to, you know, as good as these tests are with a Cologuard and the FIT test and et cetera, they're not as good as a colonoscopy in terms of diagnosing and treating it. So you can have a study that says, oh, look, you have a chance, an increased risk for cancer based on this. You still need a colonoscopy to make sure the diagnosis is correct and catch it and take it out before it turns into a cancer. But certainly the Cologuard test is a wonderful new arm. And if people are worried about procedures like that, things like this, or what Dr. Johnson had mentioned in terms of looking in the bloodstream for markers, again, they're all very good. They have to have a certain level of accuracy in finding it. And currently the most accurate exam is a colonoscopy, and you can treat it at the same time. But, you know, the future does lay in trying to cast the widest net possible. And we're not doing that at the moment.
Well, because let's face it, colonoscopies are not fun. The worst part of it is the prep for anybody who's of a certain age, or maybe they had a family history that had them get a colonoscopy. You know, you have to drink a gallon of what tastes like seawater. I mean, it's just, I'm getting sick just even thinking about it. And so
we have some newer preps now. It's not quite so bad.
Actually, I want to tell you something. I have a family friend. She lives in Italy, and she swears they give them cappuccino prep. I swear to God. And it's delicious, I swear. And it's like, I tried to find it. All my colleagues who are Italian anesthesiologists laughed. I think she was pulling. But
you're not even supposed to drink, like, it has to be clear. And I'm pretty sure a cappuccino is not clear.
It was a dream, but anyway.
Yeah.
So, but the thing is that you're right. Some people they're like, I'm not gonna do the prep, or I really am afraid to have the procedure, or I don't have anybody that can pick me up from the procedure because of sedation. So Cologuard becomes really a viable chance or alternative rather. And I think almost every insurance company now covers it.
Yeah.
The issue, though, is if there is any question about there being a polyp or a family history, colonoscopy should be first. What do you say, Dr. Johnson?
Yeah, the studies show that Cologuard is very good for detecting cancers, and it's not very good for detecting polyps. And so, that's the downside of the Cologuard. And so that if you detect polyps before they become cancerous, obviously, that's the best scenario. And so you do give away a little bit, in that regard, if you're going to just do Cologuard for screening.
So tell us about the virtual colonoscopy, because that was seen as something that, people were excited about, but practically speaking, I don't have that many people asking about that for either one of you, the virtual colonoscopy.
So the interesting about the virtual colonoscopy is basically it's called CT colonography, where they use a CT scan. So you're trading off getting a colonoscopy under sedation to getting radiation and a CAT scan. The positive of doing a radiation and CAT scan is that it looks at other parts of the body. We can maybe find a liver mass or a pancreatic mass or a kidney mass that you didn't realize it and it was incidentally found. The negative, though, is that you do need to have a bowel prep. The aspect that you point out, Dr. Albayumi, that really patients don't like is a bowel prep where you're cleaning the colon out. And then they basically, drink a lot of fluid to sort of distend your colon to get a CAT scan. So it's a little uncomfortable. It's without sedation and you get radiated, but you can look at other parts of your body. So it's semi-invasive still. It's semi-uncomfortable, and you still do a bowel prep and you do have the radiation. So you're right. At first, virtual colonoscopy was a wonderful name. So people just think, oh, I'll just put like these headsets on and my colon will be screened. No, it really is associated with, you still need a bowel prep. You still get cleansed. And if they find a polyp, you still need a colonoscopy.
Right. And, I mean, the one thing that I didn't mention about colonoscopies is the worst of it is before you even get the colonoscopy, because when you have it, you get something. I remember the first time I had one, they gave me something to sedate me. And then I opened my eyes. I'm like, when am I going to get the colonoscopy? They said, you're done. So it's actually the prep is sort of the worst part. What are some of the common misconceptions, or not even misconceptions, but myths or hesitations that people have about getting colonoscopies that either one of you have heard?
I think that I'm not sure I've heard a lot of myths about it, but I do think that the biggest issue is the disruption of daily life. And, for a lot of individuals, they do not have the type of employment that allows them to take off a day from work, get somebody to bring them in and do the whole, 9 yards. I think that really is the biggest impediment that I've, run into in terms of talking to patients.
Yeah, well, there's no question. And what you mentioned earlier on about this liquid biopsy, wouldn't that be great if we didn't have to worry about that? But this is what the best that we have for now. I'd like to talk a little bit about some of the symptoms, and then we'll go to some of the questions that are in the chat. So you mentioned, Dr. Obias, change in bowel habits. We talk about that, but Dr. Johnson, what does that mean when there's a change in your bowel habits?
Yeah, so and Vince probably can answer a little bit better because he talks to these patients on a daily basis. But all of us have our own normal, and that normal, is variable from individual to individual. And not everybody has a regular bowel movement at the same time every day. But for that individual, they generally have a normal pattern, whatever that may be.
Mm-hmm.
And when and if that pattern changes, so that the regularity that you're accustomed to becomes irregular, either in the sense of the how often the bowel movements occur, the consistency of the bowel movement, whether they be more narrow or more difficult to pass, or vice versa, more diarrhea, or the shape, the consistency, or blood in the stool in particular, are things that we would ask patients about in regards to changing their bowel habits. And as I
Mhm.
said, Vince may have more to answer, because that's kind of
Uh,
right up
Yeah,
his bailiwick.
yeah,
Lynt, that was great. Absolutely correlate with that. The things we look for, and think patients do this all the time. They glance down there after they go to the bathroom, and they kind of know if it looks kind of weird to them. And, if you start seeing that your stool looks sort of like the dark tarry or darkish looking, it could be something you ate. But if it's consistently looking like that over the next few days to weeks, that's worth, bringing it up with your doctor. They can do a test to see if there's any blood in your stool. Obviously, bright red blood could certainly be hemorrhoids, and that's the vast majority when patients come in and I see them. It's usually their hemorrhoids, but it could be something else, and we do an exam to take a look back there. If the cancer is low enough, you could have pain back there, but you could have pain with hemorrhoids. So, it is a mixed picture. It's not like you say, in breast cancer, you feel a lump. There's only a few things that could be, or trauma, but colon cancer symptoms are almost a more vague symptoms.
mhm,
That's why screening is so important, and that's why
mhm,
if you have a
mhm.
symptom, we don't hesitate to check on you, whether it is a blood test or whether it is a colonoscopy.
So let's talk about some other symptoms, because we talked about change in the bowel habits,
Right.
the change in the caliber of the stools, but we can also include abdominal pain. We can also include fatigue, because when a cancer is bleeding, you might not even see the blood, but over time it can cause anemia.
Yes.
So really, I think what you're bringing up, Dr. Obias and Dr. Johnson, is that really any change for you in whatever wherever whatever we're talking about, if you've been kind of going along in whatever your body does on a regular basis, and all of a sudden there's something, a change or a symptom that's new, that really should be checked out. But what are some of the foods or medications that can change and make your stool black?
Certainly, when you're taking iron supplements, that's a common scenario where your stool will look very dark and black and make you constipated. And it's a very common treatment, but you also have to ask why you're getting iron. Your primary care doctor may notice your blood levels are low, start giving you iron. Part of the normal workup is, if your blood levels are low, is a colonoscopy to see why you're losing blood. Because more commonly, if you're going to lose blood, it would be through the colon. You can lose it through other areas, but it becomes more of a symptom. But if it happens slowly in the colon, it could just kind of pass as dark stool and you might not notice it. So part of the workup for anemia, for low blood levels, is a colonoscopy.
Yeah, beets can also change the stool color. But every, I would say, couple of years, I see a very sad story where a woman, usually African American, who has very heavy periods, and she's anemic, and she may be in her 40s, and keeps being told, your anemia is from your heavy periods, your anemia is from your heavy periods. And then she doesn't get colon cancer screening. So I think it's important for the audience to, basically understand that yes, women get periods, but unfortunately women can also get colon cancer. And that actually is a myth. Many people for a long time thought that colon cancer was a man's disease
Yeah.
only.
Right.
So both men and women can
Yeah.
get the disease, obviously.
Well, it's a top cancer for both men and women, and a top 2 cancer killer in men and women. So
Can
I
you,
actually,
because that's a very important statistic. Can you please repeat that?
yes. So in terms of cancer incidence, it's number 3 for men and women. And in terms of patients passing away from cancer, it's number 2 leading cause in America on both sides. Obviously, breast and prostate lead the charge, and lung cancer, especially if you smoke. But colon cancer is right up there. Despite the fact that we've done great advances in screening and in treatment, it's still the #2 killer based on, CDC and cancer.org data. Um, you mentioned, screening. I take care of a lot of patients with endometriosis. And whenever we set up to do endometriosis surgery, I do colonoscopies on every single one of them because these patients have change in bowel habits and blood in their stool and anemic. And I make sure, and I've caught a couple polyps in really young women.
There was a question actually about Cologuard and whether it's something that is available for people for screening and whether the insurance companies cover that. Yes, it is meant for screening only. It is not meant to be done if there is blood in the stool. Once you have blood in the stool or a change in your bowel habits, you go right to colonoscopy. Cologuard will not be an option then. Cologuard is only for screening purposes in people that don't have a family history, don't have changes in their bowel habits, don't have anemia, don't have blood in the stool. Please let me know if I answered that question.
No.
Let me just add that also, just so there's no confusion, that I believe that the recommendation, if you're going to use Cologuard, it has to be every 3 years. It's not the same interval that you have with colonoscopy.
Absolutely, Dr. Johnson. And that reason is because Cologuard, although fairly accurate and sensitive, is not as good for screening for colon cancer as a colonoscopy. As you mentioned earlier, if you have a colonoscopy and a good, clean one, and you don't have other symptoms, you're good for 10 years. That's how accurate a colonoscopy is. But for Cologuard, you got to do it every 3 years. For other tests, the best they can get is 5 years for like a virtual colonoscopy. But you have to weigh 3 years to check every 3 years versus a colonoscopy. They're valid concerns, but yes.
I think we just want to at least have the conversation, when you go see your clinician, whether it's a doctor, nurse practitioner, or PA, important to just think about it because people really don't want to or forget because there are other competing things. I think I'll give an example. When I see patients with diabetes or high blood pressure or a lot of other chronic problems, sometimes the screenings get forgotten about.
Right.
And that's why it's so important for us as people, forget being physicians, but us as the public to say, hey, I know that my diabetes, I've got to go to the eye doctor and the podiatrist and this and that. But, you haven't asked me about colon cancer screening, right? So I think that's especially the group that I see, oftentimes screening is forgotten about. Yeah. There was a statement on the chat that I'd like to get both of your opinions on, and that is, there was a story of a young black man who wanted to get screened for colon cancer and was told no. I don't know the specifics of the story, but the question was, how do we reduce the bias in terms of screening so that everybody can get the appropriate tests that they should have, whether for screening or if they're symptomatic. Dr. Johnson, do you want to start us off?
Yeah, I think that you touched on this, and the work you do speaks to this, is that we still live in a society where there are a lot of biases. And these biases, oftentimes will influence our ability to receive the type of care that, we should be receiving. I ran across a story today of a young woman who said that her father had, not to digress too much, but her father had called to get a schedule for the COVID vaccine in Mississippi through the Mississippi Department of Health. And the person who answered the phone said, well, you do know that there's no data to support that this vaccine actually works.
What?
To her 85-year-old father. Wow. Fortunately enough that, she was a advocate, for him and reinforced the need to proceed, as well as the fact that this was not true. And so, I think that the way to get around it is that we need to kind of take control and empower ourselves to really do the type of research and to really push institutions, individuals, and others to to do what should be done in terms of providing adequate medical care, and if possible, have a surrogate who works on your behalf.
Yeah, well, there have been a lot of great initiatives. I know that Russ Parr from one of the radio shows had now for a few decades that has to do with having people go as a buddy to go to the doctor every year. People go as buddies. I think also, there's a lot of work, and this is work that we've known about for a long time now, that having a diverse physician clinician workforce improves the care that people from diverse communities get. And several studies looking at Black male physicians show that when Black men go to Black male physicians, guess what? Their life expectancy goes up. But I think that another thing that happens too, that we in the medical establishment really lose opportunities, and we tend to be a kind of a judgmental group, right? If somebody says that they can't make their colonoscopy, they're like, oh, well, they refused, or they are non-compliant. But there isn't this awareness, especially from communities that are under-resourced or where maybe lower socioeconomic status. People have competing priorities. So if you are, living in a multi-generational home where you're now having to oversee the education of your kids on the internet, that is, if you have internet or if you have enough computers for the 3 kids, and you work a couple, 3 jobs, and you have to take the 3 buses that it takes to come to GW, for example. Those are competing priorities. It doesn't have to do with a person refusing to get a test. The reality is, when you have to get food on the table, unfortunately, the colonoscopy as a screening may not be at the top of your list. And so I think that there are many aspects and I think important answers and solutions that are out there. But I think it has to do with education, first and foremost, advocates and leaders within communities. That's why we're doing these webinars, but also how people get treated once they do come, and on the phone, how they're treated when they check in to the front desk. I mean, and then the costs and the insurance and the coverage. Yeah. I want to move now to a question that just popped up about vitamins. Are there certain vitamins or supplements other than the fiber that can help to reduce cancer risk? I know that aspirin can help reduce polyps and possibly colon cancer. Can you talk about that?
Yeah, there were COX-2 inhibitor medications that had a really good association for reducing polyps, especially in those patients who had syndromes.
So when you say COX-2, what do you mean by that?
There's a whole class of medications. I'm totally blanking on the.
Like Celebrex is one.
Celebrex, right? Yeah.
Yeah.
But
not the aspirin.
Aspirin has been shown. So, but I think you'd have to say the risk of taking an aspirin chronically versus lowering your overall risk of cancer. And I have not advocated for my patients to take aspirin just to reduce that risk. But you're right, large studies have shown maybe a slight improvement. There was a question about probiotics. I think probiotics are associated with maybe making yourself more regular, but I don't think it's going to reduce your risk for colon cancer. Mm-hmm. But there were certain types, like Celebrex was noted to reduce polyps, but it also had a cardiac side effect. And so if you had a syndrome, we might give that to you. But for the general population, we weren't recommending it.
Yeah. The problem, though, with the probiotics is that there are, how many thousands of different types of organisms. That's part of it. probiotics is not just one type of organism. It's actually, there can be tens of thousands, and that's the problem. We just don't know which one may have a beneficial effect because there are so many. But what I tell people in general, a part of a healthy diet is to try to eat yogurt with live cultures. That's something that is helpful. From the standpoint of a baby aspirin, again, that is a conversation to have with your clinician, because if there is a strong family history of cancer, that may be something to consider, because it's not just colon cancer reduction, it's other kinds of cancer. But these are the kinds of recommendations we really cannot make in a webinar like this, because there's so many other considerations of a individual's history that we really would, you need to really discuss that with your clinician.
Dr. Albayumi, can you comment on, particularly for African Americans, vitamin D? I mean, there is some research that suggests that, vitamin D supplementation, because of chronic low levels in African Americans, might be beneficial. What's your—
Yeah, I tell you, I have this discussion / argument with my chair of medicine and the vice chair all the time. I have always felt that vitamin D is important, and that is one thing that's also been looked at in COVID, because when I have my patients who are of African descent, the vitamin D levels are some of the lowest that I ever see. They're low in other groups too, but especially in African Americans. And I think part of the problem with the studies of showing whether vitamin D can be helpful or not is that they're not going on for 10 years. How can we know if there's going to be a beneficial impact of taking vitamin D supplementation on something about if it's a cancer that will take 10 years to develop? I personally tell people to take vitamin D supplements. And again, you should have your clinician check your level. But I personally, even though the data is not necessarily as strong as my chair and vice chair want it to be, I think that there's enough data that shows that vitamin D should be supplemented in almost everybody. Now, just this week, I saw somebody that was a little too aggressive with their vitamin D supplementation and was actually toxic. Okay, you can get too much vitamin D, but over 20 years, he's the first person that I've ever seen that with. But I personally believe that vitamin D supplementation is important. Did that answer your question, Dr. Johnson?
Yes, yes.
And for the question that was on the chat, I hope we answered that.
Yeah.
So, somebody says, I'm 66, and forgive me because I'm on my phone, it blocks. I'm 66 and I take vitamin D every day. Great, that should be. I think that's good. I take vitamin D every day, and I'm not quite 66, but I take it too. So now let's talk about, you're both surgeons. I didn't even ask you about anything. So somebody is found to have a cancer, and I refer them to you, Dr. Obias. What are the options that people have?
Right. Obviously, we talk about, the colonoscopy, making sure they have it. So sometimes cancers are found without a colonoscopy, say on a rectal exam. So make sure they have a full colonoscopy, and make sure we get a scan for the chest and the abdomen and pelvis, because the most common spread for colon cancer is the liver, and the second most is the lung. And so we need to make sure that this cancer has not spread beyond the colon, and we will get those scans. Many times, though, even if it's spread to the liver, we have great modalities and great surgeons like Dr. Johnson, when we can do surgeries to take both the cancer and the colon and the liver at the same time. And many times we do it through tiny incisions. At GW, I was the first person to do robotics for colorectal cancer in 2009 in Washington, D.C., and have the series. Dr. Johnson does minimally invasive liver surgery all the time, as well as pancreas surgery. So, we are able to get a large amount of these cancers. That being said, after the surgery, chemotherapy is invariably is used to treat patients. And that's where our team, led by Dr. George Kim, can treat these patients afterwards. But we do have advanced modalities, whether it is minimally invasive or robotic or laparoscopy, or even ablation techniques that Dr. Johnson can elucidate. and chat about in terms of treating the colon cancer and where it has spread.
So, but not all colon cancer has spread, right? Sometimes you just go in and you do this laparoscopic surgery with these small incisions and you clip out the section of the intestine that has the cancer, and then you're done. You're cured if it's small enough. Is that right?
Absolutely. And I think one of the myths is that when people hear the word colon cancer, they think they're going to get a bag. They think they're going
Oh,
to get a bag or a colostomy. They call it a bag, and basically where the colon is pushed outside your body. And that actually will happen more often in an emergency, and rather than when cancer is caught in a screening scenario like colonoscopy. And even if it does happen, it's many times not permanent. I would say the vast majority of patients that I take care of for colon cancer and rectal cancer get put back together. And very rarely do we do it for colon or rectal cancer. Now, anal cancer is slightly different, but even there, the therapy that Dr. Kim provides is about 90% effective because anal cancer is so sensitive to chemoradiation.
mhm.
Still, if you take a look at it, that's a big myth, is that one, if I have colon cancer, I'm going to die. There's nothing you can do. Or two, I'm going to have a bag. And the vast majority of times, it's very treatable, like you mentioned.
Oh, well, that's so good to hear. So, Dr. Johnson, how do you and Dr. Obias work together when a patient has colon cancer that has spread to the liver? I mean, is it even possible to have surgery once it's spread to the liver?
Yeah, so colon cancer is one of those very few cancers that you can have stage 4 cancer. That is cancer that has metastasized to another organ, and you can still be cured.
Wow.
The colon, all of the blood drainage from the colon goes into the liver in order to be processed. And so the first site of spread to another organ is to the liver generally. And
Mhm.
so that oftentimes we will see patients that have a colon cancer and also spread to the liver at the same time. Most of those patients, when they're diagnosed in that way, will get some chemotherapy initially for a few months. And then Dr. Bias and I will jointly go in. He will take out the colon cancer, and then I will take out the cancer that has spread to the liver.
Mhm.
It becomes a little bit more complicated if there are more than 1 or 2 spots in the liver, and those spots are on different sides of the liver. Because if it's on one side, it's very easy. We can take that side out, the other side remains in, and the liver functions normally, and there's enough liver left behind.
Mhm.
But if there's on both sides, then it becomes a little bit complicated. And sometimes we have to do what's called a 2-stage resection, where we take out part of the cancer in the liver, and then we try to get the liver to grow, and then we come back several weeks later and take out the other part. But we work very well together, and we've done a number of cases together, and typically those patients do extremely well. Following the surgery, then they go on to get an additional few months of chemotherapy before their treatment protocol is completely ended.
These patients, as Dr. Johnson mentions, are extremely complicated. And one of the benefits that we have at GW is we have a tumor board where we review all the patients' studies and scans every 2 weeks. And Dr. Johnson is one of the major organizers of this. And there's studies that demonstrate that patients who go to institutions that have tumor boards have a better outcome. And by reviewing this and having the oncologist and the radiation oncologist and everyone and the radiologist and pathologist all in the room, we can make plans on the spot and stay consistent with it. So, because these patients are extremely complicated, have multiple treatments, either radiation, then chemo, then surgery, then back to chemo. And it's important to have this level of organization. So that's a big positive of coming to a larger center.
And that's true of really most academic institutions. Tumor boards are really part and parcel of any cancer center in any academic institution. So I just want to sum up in the last 2 minutes that we have, because somebody came around with another question about the modality of screening if a person has a family history. That really should be a colonoscopy if there is a family history, especially if that person was very young when they were diagnosed, meaning mother, father, sister, brother with colon cancer, or a child then you really need to have a talk with your doctor about getting a colonoscopy. If there is, Dr. Obias mentioned, polyps in the family, that's another reason to get a colonoscopy. I think what I've heard from both of you gentlemen is, first of all, it's important to get screened for colon cancer. If you're having any symptoms of blood in the stools, abdominal pain, anemia, if you're having a change in what your regular bowel movement habits are, or the size and the color consistency of the bowel of the stools, guess what? You should talk to your clinician. And also remember that once we have a procedure, we'll check on our friends. Did you have your colonoscopy? Did you go? Do you need a ride? So I'm going to sort of close out by asking you, do you have any final words about what each of us can do, Dr. Johnson, to improve colon cancer screening rates among everybody, but particularly in communities that are under-resourced or underserved or minoritized?
My parting words would be to kind of demystify the process of screening and colonoscopy, and emphasize how important it is to save lives. That's the most important message I think that folks can take away. As long as we are able to, the whole purpose of screening is to catch cancers early where we can cure it.
Thank you. Dr. Obias, any parting words?
Absolutely. I think that it's important that even during times of this pandemic that we take care of ourselves. We saw a 90% drop in screening colonoscopies during COVID. And it's not too late to get your colonoscopy. It is an absolutely treatable and preventable cancer. If a colonoscopy or any type of test that were mentioned earlier, you can prevent colon cancer. And if you have it, it's very treatable. And I think not to be scared of the colonoscopy or these tests. It's good to know than not to know, because if you do have it, then your children are at risk as well. So you should know first.
Mm-hmm. That's a really good point. And I think with that, I'm going to thank both of you gentlemen for giving us your time and sharing your knowledge and experience. Dr. Johnson, Dr. Obias, thank you so much. And for those of you that may have come in at the tail end of this, or you want to share this webinar, please visit the Rodham Institute website, because we've got this webinar and all the other previous webinars on there, and you can watch it. So thank you for joining us, and enjoy the rest of your evening. Take care. Bye-bye.
Thank you very much.
Bye.
Thank you.